Welcome to this explainer. Today, we're stripping down IV fluid therapy into a clean, highly actionable guide for your clinical practice. Whether you're prepping for a shift or just want a sharper understanding of fluid manipulation, let's look at exactly what's happening beneath the skin.
Okay, here's our blueprint for today. We're going to look at our two types of IV fluids, explore the crystalloid tonicity spectrum, and then we're diving straight into the troubleshoot phase, covering infiltration, phlebitis, hematomas, infection, and finally the severe risk of extravasation.
Section 1. Two types of IV fluids, crystalloids versus colloids.
So let's start with the baseline of our toolkit. We've got two main categories here based on how they're built at the molecular level. Crystalloids are basically your go-to hydration tools. The solutes are completely dissolved, making them crystal clear, literally. If you shine a light through them, the beam passes right through, meaning there's no Tyndall-light scattering effect. Colloids, on the other hand, are the heavy hitters we use for severe hypovolemic shock. They contain large, insoluble particles suspended in the liquid. Because of those big particles, they look kind of viscous or opalescent, and they actually do scatter light. That's the Tyndall effect. They stick around in the blood vessels longer to act as major plasma volume expanders.
Moving right along to Section 2, the crystalloid tonicity spectrum and how we direct fluid movement.
Let's zoom in on those clear crystalloids. It's not just about pushing fluids, right? It's about knowing exactly where that fluid is going to go once it enters the body. And that is all dictated by solute concentration. For instance, hypotonic fluids, like less than 0.9% normal saline, have a lower concentration than the inside of the cell, so they push water into the cells. Isotonic fluids, like your standard 0.9% normal saline, have an equal concentration, so they just expand the vascular volume without shifting water in or out of the cells. And then you have hypertonic fluids, like 3% normal saline. These guys have a higher concentration, so they aggressively pull fluid out of the tissues and drag it right back into the vascular space. You really have to know your target before you hang that bag.
Section 3. Complications, specifically infiltration and phlebitis. Let's talk about identifying local failures.
Okay, so you've set everything up perfectly, but what happens when the system fails? The crucial thing to figure out first is the location of the failure. Infiltration happens when IV fluid accidentally leaks out of the vein and pools into the surrounding tissue. It's a mechanical leak. Phlebitis, though, that's a biological reaction. It's an inflammation of the actual blood vessel itself, which can sometimes even involve a clot, known as thrombophlebitis. Because the locations are different, the physical symptoms are completely stark too. With infiltration, you've got fluid literally building up in the tissue. This stretches the skin, leaving the area swollen, noticeably cold to the touch, and it usually causes pain or numbness. Phlebitis is an inflammatory response. The body is fighting back, so it creates a hot, red, and highly tender area right along the track of the vein. So just remember, cool and swollen for infiltration versus hot and red for phlebitis. How do they manage these? Well, our clinical response builds from a shared first step for both: remove the IV line. You'll also want to apply a warm compress in both scenarios. But with infiltration specifically, elevating the extremity is a super important extra step to help gravity drain that leaked fluid away. Now, there is one massive warning covering both of these situations. Do not rub the area. Seriously, rubbing can cause even more tissue damage or, worse, dislodge a clot if one is forming.
All right. On to Section 4, complications involving hematoma and infection. We're looking at blood and biology here.
Here, we're contrasting a localized blood issue with the systemic biological threat. A hematoma is basically a collection of blood pooling in the surrounding tissues because the vessel wall got breached. An infection, on the other hand, means a microorganism has successfully used your IV line as a direct highway right into the patient's body.
The presentation for these two couldn't be more different. A hematoma is going to give you a very localized, hard, painful lump right at the site, accompanied by visible bruising. An infection is going to trigger whole-body alarm bells. You're not just looking at the IV site anymore, you're looking at the monitor. The patient will likely show systemic signs like tachycardia, an elevated heart rate, along with chills, a fever, and some localized redness and swelling.
So our responses here have to be completely divergent. For a hematoma, we're dealing with active bleeding. You need to elevate the extremity, apply direct pressure to promote clotting, and throw on an ice compress to cause vasoconstriction. But for an infection, your priorities shift instantly. You still pull the line, absolutely, but then you've got to get a blood culture sent off immediately to identify the invader and then start administering targeted antibiotics.
Which brings us to Section 5, the severe risk of extravasation. This is a true chemical emergency that requires your flawless intervention.
Extravasation might sound a lot like infiltration. I mean, it is fluid leaking into the tissue. But the critical defining difference is the specific type of fluid. Extravasation is the accidental leakage of a highly toxic vesicant solution or medication from the blood vessel into the surrounding tissue.
The stakes here are incredibly high. Why? Because these vesicant drugs don't just sit in the tissue harmlessly. They actively destroy it. They cause severe chemical irritation, tissue sloughing, blistering, and progressive necrosis, which literally means the tissue begins to die.
You absolutely cannot miss these warning signs. If the patient reports a sudden burning or stinging sensation, you need to act instantly. Look closely at the site for severe pain, erythema, localized swelling, and the real red flags, blistering or a dark ischemic discoloration. That discoloration means the blood supply is being choked off and the tissue is suffering.
When you see those signs, your protocol has to be totally flawless. Step 1, stop the infusion immediately. Step 2, and this is a big one, do not just yank the needle out. First, you must aspirate or pull back any residual drug left in the IV cannula, using a syringe to minimize the amount of vesicant in the tissue. Step 3, again, absolutely do not rub the area. And finally, depending on the exact drug that leaked, you'll apply a cold compress or deploy a specific chemical antidote, like a vinca alkaloid or a vasopressor.
So here's what it all boils down to. The difference between a routine fluid shift and a permanent, devastating tissue injury comes down entirely to your structured vigilance and foundational knowledge. By really understanding whether a fluid is pushing or pulling, and by recognizing the exact physical signs of a local leak versus systemic infection, you become the primary shield for your patient. How many critical tissue injuries will you prevent on your very next shift just by looking a little closer at that IV site? Keep that in mind, stay sharp out there, and I'll see you in the next explainer.